Alrighty, so I think in the interest of time, let's get going and we'll continue to let people trickle in. But thank you so much, everyone, for joining us today. My name is Josh. I'm the digital marketing manager at Vantiq, and I'll be your host for today's session, How Hospitals Are Leveraging AI to Improve Discharge and Patient Flow in 2026. A few quick housekeeping notes before we begin. The webinar will begin with a brief welcome and introduction, followed by a presentation and live demo from the TransformativeMed team. After this, we'll move into a live fireside chat and Q&A. At any time, please drop your questions in the chat box below. We'll be make sure to get to those at the end. So before I begin, I want to introduce our speakers. First, Dr. Ryan Vega, Chief Health Officer at Vantiq and former Chief Innovation Officer at the Veterans Health Administration, the largest integrated health system in the United States. Ryan also serves as a physician in residence at the Digital Medicine Society and holds academic roles at Georgetown and George Washington University. Also joining Ryan is David Sohn, CEO and co-founder of TransformativeMed. David spent a decade at the University of Washington, where he became the application architect for the UW Medicine's EHR implementation and helped develop one of the first EHR connected app platforms in the industry. Also joining is Aharon tenBroek, VP of Client Services at TransformativeMed, who brings over 2 decades of experience across healthcare operations and clinical systems with leadership roles at the University of Washington Medicine and Harborview Medical Center, along with a background as a registered nurse. And with that, I will hand it over to you, David.
And I think we're going to have Ryan kick off. You're muted, Ryan.
I'm always happy to kick off. I want to thank all the participants for joining. I anticipate both an interesting discussion and a unique view at how organizations are leveraging AI to really solve and close some of the gaps that hospitals face. One of the big things that we always think about is not just how do I apply AI, but how do I apply AI in a way that's really meaningful to the business side, to the clinical side, and really to the care side. And I think that's what you're going to hear from TransformativeMed today. Just some context, because I think it's important to understand a little bit about both companies, and David will introduce TransformativeMed. I personally used the course platform and the tool when I was a resident. Feels like ages ago. So I was deeply familiar with the technology and had a unique opportunity to join Vantiq several years ago, mostly because what I saw was a transformative technology that was solving the really hard problems with AI that a lot of folks sort of are coming to realize are going to be important. So when I think of AI, Vantiq, I think of really 3 important ingredients. I think of the core infrastructure that enables you to run applications, particularly AI applications at scale. That's the reliability and the availability and the securability, right? All those mission critical abilities are baked into the infrastructure as not sort of a second class citizen, but really fundamental. And this is really, really important. And we've solved a lot of the hard problems of making that fit for purpose. The second is really what I think of as the operating system, which if you think of healthcare or really any real world scenario, the world doesn't really move like computers did, in the sense that A has to happen, then B has to happen, then C has to happen, then D has to happen. The world's often unpredictable and, as we call it, highly asynchronous. And you don't want to slow things down while you're waiting for an agent to respond to another agent, or while you're waiting for the system to do its task. You want things to be happening asynchronously, but in a way that really conforms to the workflow. As a practicing doc, I may be working with a patient while waiting for the nurse to call me back. The social worker is also working in a different system that requires something that he or she needs to wait on that may take an hour. That's the real world. Things are happening randomly and sometimes unpredictable. You need an operating system that can handle that can create context at scale. Data in medicine really is meaningless. It's about the context of the conversation or the patient or what that data means. And so solving that is something the company spent a lot of time doing and is going to be really vital for how organizations leverage AI and AI transformations in the future. And then we also integrate and provide the ability to sort of build these applications and systems really easily, or connect to the applications or systems you're building externally. So sort of a bring your own or design your own becomes really important. So I wanted to provide that foundation because I think it helps contextualize what you're going to see. And with that, David, if you want to go into a little bit about transformative med and kind of set the stage, and then I know we're going to see some demos, which I'm excited about.
Absolutely. Thank you, Ryan, and great background. So for everybody on the webinar, we want to just give you a little background on who Transformative Med is so you can get kind of a mental picture of what we're doing and how we fit into the market. And then we're going to move on to the specific use case we're tackling around agentic automation of discharge planning. And that'll be a little bit of a background on the problem as well as the live demo. So Transformative Med as a company, we're really focused historically on the clinician, helping them provide better care, get better patient outcomes, spend less time in the electronic health record with burdensome tasks. And historically, we did that with a bunch of applications built on our Cores platform. As AI has evolved, we have been evolving our platform into a hybrid between kind of legacy classic application platforms and an agentic clinical operating system, meaning that we can embed agents into the data flow, into the workflow, and start to really automate tasks in ways that weren't truly possible prior to large language models. And so we do a lot of things. We cover a lot of bases here. We've probably got 50 plus pre-built application and modules that we deploy in the market today. And for all of those, we're layering on AI and automation. But today we're going to look at kind of a new effort to build an advanced discharge planning process in collaboration with one of our customers. As a company, we just won Best in Class for Clinician Digital Workflow. So hopefully this kind of underpins the proof points around some of the value we bring in terms of how clinicians operate with our applications to improve their EHR experience. 100 plus hospitals, really the leader in kind of the smart in-pages space. And 100% of our client customers are biased again. I'll note for the audience, we focus today primarily on Oracle Health. We're looking at expanding next year into Meditech and InterSystems. We do have an Epic implementation. Always interested in conversations around Epic, but it's not a priority for expansion at the moment due to some of the closed walled garden challenges there. So hopefully that just gives you a little context. Underpinning this, kind of the what and the how, our Cores platform, which has really been now enabled with agentic technologies, historically has had the foundations of really deep EHR workflow integration, very, very deep EHR data integration, meaning we can read and write just about anything in the record, everything from orders to clinical documentation, to reference data or even workflow data. We have a mobile application that underpins how people tend to interact with our applications. And then on top of that, we've been building our AI data platform that deals with how do you transform some of the non-discrete data in the EHR into usable insights, and the Vantiq orchestration platform, which really allows us to put agents and automate workflows, where in the past we'd have to build either brittle rules or force people to do the usual point and click. Within this, we have a lot of large language model flexibility that's built into Vantiq, and it's kind of built into how we've been thinking about building LLM automations in healthcare as those things continue to evolve very quickly. How we engage health systems, we start out by quickly installing the platform. We're leveraging open APIs to make this really a plug and play experience. It is not a heavy lift for customers. And from there, our customers do one of two things. Historically, they mostly installed pre-built applications and modules that solved existing problems, and then looked at innovation. We are starting to see more customers come to us with automation use cases and saying they want to do this first. So I think in the last year or so, we've started to maybe flip the script and see it 50-50 between people wanting stuff that's out of the box versus wanting to take new tools to solve big, historically challenging problems. And discharge planning is one of those examples. As far as how we think about AI strategy, just to provide a little background on that, we're really focused on complementing what the electronic health record already does. There's a lot of really cool stuff that Epic, Oracle, Meditech, you name it, are doing. The gaps right now really are around some of that advanced automation. So we're heavily focused on the automation space first. We're tackling this in a way where we're tying together hybrid workflows, meaning you have to have really advanced legacy classic applications paired up with agentic automation to make it work. Because hospital operations are complex, because a lot of people are involved, if you just throw an agent at this problem, you're not going to solve it. So we're really focused on how we tie together all this legacy application and EHR workflow with agents. And then the last one is we're leveraging these emerging toolkits like Vantiq. We think this is really important, and I'll talk a little bit more about this later and in the fireside chat. But the world is moving so fast. If we had to build the foundations on our own, whatever we developed would be out of, it would no longer be relevant and would be dated by the time we deployed it. So Vantiq is giving us the ability to move quickly at the speed of the current market and deal with things like agentic orchestration, multi-agent workflows, asynchronous workflows, things that historically would have required a lot of underpinning engineering. So that's a big part of why we brought them into our technology stack. And we'll highlight how we're leveraging them for part of our workflow solutions. So from this, I'm going to just really quickly give you a little background on the problem and the solution vision, and then we'll jump into the demo in the chat. So in case we don't have clinicians or folks that have a lot of experience in the hospital, I'll just paint the background. Everybody who isn't in medicine thinks that if you're in the hospital, the doctor or the nurse shows up and says, yay, you're going home, and everything's great. But the reality is, behind the scenes, you have a big, complex care team with different specialties and disciplines that rarely work in the same exact geographical location. The specialists are moving throughout the hospital. People are documenting information in the record that often isn't discrete and is not easily processed. So everybody's writing progress notes, et cetera. And those notes are going to contain insights and information that historically were hard to feed into systems for automation. LLMs are changing that. At the same time, there's a lot of information on what the plan is and what people are doing that simply hasn't been documented yet, or maybe even won't go into a note in detail. And so basically it's in the clinicians' brains. And the way this works is you have discharge coordinators or case managers that are reviewing the charts and then calling or talking to the clinicians. They might page them, they might call them, they might message them, or they might meet with them in interdisciplinary rounds to try and figure out what's going on, what's the plan, have you done your work, are there things to get done, and trying to keep the whole process organized and moving. As we look at how agentic AI can help with this, there's a couple real low-hanging use cases we focused on first, and then some advanced things we'll talk about at the end of the presentation. So first, LLMs are going to be really good at looking at clinical notes and extracting targeted information and insights. So if we want to know that somebody already documented the anticipated discharge date, the need for DME, a specific plan, etc., LLMs can process these notes in real time and then automatically update the tools where we're tracking discharge progress, barriers, plans, etc. Additionally, LLMs with language are very good at chat and increasingly things like voice calls. So we're integrating the ability to reach out to the clinician in real time to both gather information and insights that may not be documented, ask them questions, or provide reminders or recommendations. So if the patient's being cleared, the consultants may want to know when that happens so they can jump in and finish up last minute work so we can push out that information in real time. As we do all of this within the context of our applications and platforms, some fairly obvious, hopefully, ROI use cases that we're targeting with our early adopters. So right off the bat, we think we can target discharge before noon rates. We've done non-agentic discharge planning and have seen notable improvements, around 18% improvements in discharge before noon. We think we can improve that further. We also think we can improve clinician efficiency across the board by reducing chart reviews and the needs to do things like constantly answer calls or try to, show up on interdisciplinary rounds and spend extra time on it. And then we ultimately think there's an opportunity to reduce some of the FTE costs related to discharge coordination, which we believe ultimately is going to free up clinicians like case managers to focus on clinical work and focus on things like value-based care, where there's a general shortage of these specialists. And then longer term, like we said, streamlining interdisciplinary rounds, reducing length of stay, and as I mentioned, getting social workers back to things like value-based care and actual clinical work versus project management. So with that being said, I'm going to stop here. Aaron, if you want to take over the screen, Aaron's going to walk us through a little overview of what we've built and are deploying.
Thank you, David. Thanks, Ryan. Everybody see my screen?
Yes.
Excellent. Thank you. So what we're looking at here is our new discharge planning patient list component. It integrates into our existing platform for inpatient care and patient list management. What we're going to do is review this a little bit, give you a quick orientation, and then I'll show you kind of some bells and whistles of what we're working on. So with this patient list kind of dashboard, we're pulling in information from the chart like length of stay, insurance information. Oh, let me back up one piece. This view would be used by whomever is going to be taking charge of actual discharge coordination and planning. So in the inpatient world, that could be a social work. It could be an actual discharge planning person. At some places, they're called continuity of care nurses. It's role-based, not specific person-based. And not all discharges require someone who's going to be coordinating all that information. Some discharges are going to be pretty simple, where the primary service and that provider will just do everything. In others, you have a lot of, like Dave said, moving pieces kind of happening behind the scenes to help get that patient discharged. So we're pulling in things from the medical record, which we have done for almost 15 years now. This we pull in orders, discharge documentation, med rec status, etc. That's just an example. As we move over here to the right, this is our new component. So and we'll dive into a little bit of this. So we have a discharge readiness AI component, and I'll show you that in a moment. This is the discharge status, basically the overall discharge status for a patient. And this is fed information from all of these columns on the right-hand side. So we have the discharge disposition. These columns are interactive. So if I wanted to update this, I could just click in here and say, actually, we need a bed with home, and that's needed. It hasn't been ordered yet, so I can do that and save, and it updates here right away. Same thing with, yeah, go ahead.
And Aaron, I'll just add real quick. So this tends to be integrated directly into the AHR view. So you're going to see this inside your electronic medical record. And when we make these updates, we're writing them back to the record. So in almost all cases, there is a place where disposition and some of these details are stored. We are not only summarizing the workflow, we're pushing it back in. And yeah, continue, Aaron.
No, thank you very much. So that's the same for the discharge date, the discharge time. For the pick list, you just chart AM or PM, but when you hover over this, it gives you the specific time. This can all write back and forth with the EHR. So we can place information into the chart, read from it, etc. So that's your basic, where's this patient going and when? And then to the right here, we've got the discharge coordinator, discharge readiness, the discharge, any consults that the patient has been seen by. So you hover over this, it'll give you any outstanding consults and the status of those consults. The primary team, they'll be documenting when they think the patient will be medically ready for discharge. And then to the right, we have specific consult teams. This view is just for our current work. These, you won't have 27 different consult service columns. These will be all combined into this discharge consult column. And when you hover over it, you'll then be able to come here and request an update. So this will all be combined into one column, but I have it out here for our demo today. And we have a column for what the nurse may be thinking about the discharge, physical, clinical pharmacy, PT, OT, speech, and RT. You can see here which of these teams are following which patient by this information here. And those can be added by consultation orders, which we actually do today. You place a consultation order to cardiology, and that patient will be added to the cardiology consult list and appear here. So that's a basic overview. The discharge status column, again, gives you an overview of when you hover of which services have seen the patient and are cleared with the green check mark, no longer following the patient, or ones that are still active and are still following the patient. The discharge planning person can click in here and it opens up the details slide out panel on the right-hand side. And this is where you can document the actual time for discharge, the same disposition information that we saw in the column, needed or it's confirmed. You have a spot here to keep track of notes and things you may want to be reminded about. We can add discrete tasks here on the right-hand side, and I'll tell you a little bit more about that. This is the main kind of documentation area for this service. And in our application, the actual service or team for patients on this list is the discharge planning group. And they have a way to document their view of the world as far as the discharge readiness for this patient. It is not connected necessarily to what other people are documenting. Depending on the environment you work in your organization and how big it is, a lot of the time, the discharge coordinator type person is actually the person in the know almost all the time about what's actually happening. And so they can say, oh, we actually have not ordered the DME yet, but everything else is taken care of. But I want to keep track of some care coordination barriers so the patient can go home or anything else. This is basically just for them to have a high level view of where is the status for this patient. They can then sort the information so they can prioritize who they need to follow up with in the morning. And then when the patient is ready, they just click here and it clears the other statuses. And then it'll say out here on the patient list that they're ready to go. The bottom section are, again, that same view of other services that have been following a patient. And C for consult here next to cardiology, they're still they're following, but you see it's green. They're following, but the patient can be discharged. A lot of the times this will happen from a group like maybe neurology or neurosurgery. It says, we're done with the patient. We just call us if you need us. We don't need to see the patient, but call us the morning of discharge so we can update our discharge instructions based on how long the patient's actually been in the hospital before they leave.
And Aaron, I'll just add a couple things because I know we're going to move on to some of the automatic data updating. But if you go back to that real quick, outside of just the agentic updates, if a client already has a spot where case managers are documenting disposition, discharge date, etc., we already link up those fields asynchronously. So, there's ways things flow in from classic EHR workflows like classic documentation forms, or there's a way where the agent collects information and then updates it and makes it more accurate. So we're going to see that real quickly here, how we kind of have both that legacy integration approach as well as the agentic.
And so before I do that, just to show you that view with the slide out panel is the same view for everyone. So if I click on physical therapy, so as an example, it opens up that view, but it opens up the physical therapy section ready for documentation. And this is an example of the consult readiness, basically status. So a consultant can say, we're signed off, don't need to see the patient anymore, DC okay. We're following the patient, but don't hold up the discharge. It's okay to discharge the patient, or it's an active consult, do not discharge this patient. All right, so backing up a little bit, we have this discharge readiness column. You hover over it. It is pulling information and categorizing tasks that need to be done for the patient to be discharged within a certain amount of time. And it can assign those tasks to the appropriate role or party within the hospital. So it gives you, go ahead.
And that's specifically generated through the LLM. So we're getting into some of the AI content where we're looking at information on outstanding tasks that flow back into the workflow.
And another one that they've kind of touched on before is the ability, LLMs are really good at summarizing clinical notes and other information, but not necessarily identifying discrete values that you can then pull out and place into maybe like a task list. And I'm going to show you that right now. So if we take a look at this patient here, Craig, and we open up his details, there's no tasks here. And I'm going to flip into the record. I'm going to go ahead and place a post-op note on this patient. And they had an ORIF of their left lower extremity, and I just pasted in here some text. They'll need a wheelchair with transfer board at home and a CPM machine for 6 weeks. I'm going to assign that. So here it is here. And now I'll hop back to our list. And we have Craig here. One of the things we're going to be working on is a way to kind of give you a spot where you can see if you have new tasks without drilling down into the details. But now if I open up his information here, AI has pulled out that they need a wheelchair with a transfer board and a CPM machine. It's interesting that it actually pulled out and tells us what CPM stands for 6 weeks. And that can then be posted to this task list. And those tasks can be shared. So maybe you want to send those needs for DME ordering to the discharge planning group and the primary service, or one or the other, and then whomever takes care of it, it falls off both. All right. The really fun part here are these little chat bubbles on these columns. And so for demo purposes, we kept a click here to kick off the demo of what will happen. In the future, this will actually happen autonomously. We already have in our environment working with Vantiq multiple agents that are specific to specific services for finding out information. So we have agents that are for rehab therapies to follow up on maybe a PT consult. We have an agent that's in charge of gathering medical readiness from the primary team information. We have an agent for discharge disposition, an agent for medical consults versus non-medical consults, et cetera. So you can actually get some pretty nice information. I'm just going to show you how this actually does work. So if we have the primary team here, and they have said that the patient's probably going to be ready day after tomorrow, not today. But everything else, let's just say for fun, is done. The patient could be discharged today if the primary team says it's okay. So I click the little chat button and we get our spinner. And I'm going to hop over to our mobile application. And I don't know if you were able to hear the little beep, but my phone pinged. So this goes straight to my phone and our mobile app. Here's the patient. Click into them. Here is our chat. So this is happening real time. Is the patient medically ready for discharge? And we're going to say, yes, CT this morning, clear, will place DC order now. So we're getting information to them. And the agent says, great, that's actually all the information I needed. I'll update the discharge plan. And so now when we hop back, this has changed now on BB1. It was yellow with a tomorrow, day after tomorrow, and now it's today. And it did it all by itself. And that is true. And this is going to be the way it works for any of these. So if I need to ask PT, this is the only thing holding up the patient from being discharged later today. Where are you on your consult for crutch training? Things like that. We can reach out to the primary service just like we did. We can reach out to a medical consult like cardiology and say, hey, the patient's actually ready to go by the primary team. Social work has disposition set. Are you done with your consult or not? I can't find a note in the last 2 days. This isn't meant to be used just for general updates at any given time, especially when we have this working and the agents are working together and autonomously, where we'll actually have a discharge planning agent coordinating this team of agents gathering this information. They'll only reach out to, say, cardiology when certain criteria is met. Basically, everybody else has signed off on this patient being able to leave today. I cannot find any documentation from cardiology since yesterday. I'm going to ping cardiology and ask them where they are with their consult. And that's about it, Dave. I'll stop sharing.
Awesome. Well, thank you, Aaron. That was great. I'm going to flip back to the screen. We'll recap a few things on current state and roadmap, and then we'll just move into the Q&A session. So let me get back to this. Click us forward. So I'm just going to highlight again really quick kind of where Vantiq has critically fit into this for us. And I'll hit on a couple points. One, the world, and I already said this, is simply moving too fast for most engineering groups to build their own foundations for AI automation. Just like most groups can't build large language models, I mean, there are ways to open source this, but the reality is that commercial products are moving so fast that tends to be the best place to work today. The same is true of the underlying technology that allows agents to interoperate and work together. And so we saw this as really critical to not only keeping up with the market, but really being able to kind of take thought leadership and make a big impact quick. The event-driven architecture is critical for us. We're doing all of this in real time. One of our really unique things is we are seeing real-time events in the EHR, and we don't want to have to wait for batch updates or people to come together to figure out what's happening. If a patient's ready and all we need to do is ask cardiology, when that becomes true, when that event happens, we need to reach out. And if they clear them, we need to tell the team to start planning to get them out today if they can. It does have a real bottom line impact to the hospital. The other one is the multi-agent support. So for folks that haven't spent a lot of time with this, LLMs are prone to kind of drifting off task if they're given really complex big tasks or making stuff up, so hallucinating. There's not a massive risk for what we're doing because we're not actually proposing clinical interventions. We're coordinating the plan of how people are coordinating the operations of care, but we still want stuff to be reliable. So one way you do this is you make the agents and the tasks they do more discrete and smaller, and then you organize them together. And so Vantiq gives us a great way to have little focused agents that do one thing really well, and that reduces what can be unreliability issues with LLMs. And then from there, we can orchestrate them together. So again, an agent whose job is to coordinate versus doing the tasks. And as we get into things that are a little more clinical or more complex or that need to be higher reliability, a really common emerging pattern is to use challenge agents, where essentially one agent is told to do a thing and another agent is told independently to look at it, tell if it did it right. And you see a general kind of nonlinear reduction in risk when you do that approach. And so Vantiq gives us the ability to do all of those things and do it easily. A lot of point, click, drop type of stuff. We don't have to spend a lot of engineering time, which gets to the last point. One, building these agents in Vantiq has actually been really easy. Aaron, who is not an engineer, was in there yesterday changing the prompts because he wanted it to say different things for a particular use case. As we get into individual customers, how their primary care team works, how their consultants work, if they're a big academic, they're a mid-sized academic, they're a community health system, there's all going to be these little slight variants in responsibility and ownership and what people do. The low no-code platform gives us the ability to do that quickly without putting engineers in place to do it. And that's absolutely necessary to kind of meet the market and people where they really work. So Vantiq's bringing all of that to us, and I think it may come up in the chat session. We can talk more about that. And then the last thing I'll do, we showed you what we're doing. It's just good to kind of tell you where we're at and where we're going. So we've got, we're going to start with one really deeply engaged academic medical center to start with on our beta rollout. I expect we'll roll in more this year, but they're a longtime customer, deeply engaged with us. They're going to be taking our advanced discharge planning workflow. They're going to be embedding some of this content into the physician nursing work list, so where they normally work. They're going to focus on the agentic chat. We may integrate some of our chat with their existing secure messaging platforms, discharge activity reminders, and processing clinical notes. We're not going to do everything you could find in a note on day one, but we're going to start with the big 80% of things that impact most workflows and then expand. So DME, discharge before noon, anticipated discharge date. I know there's some other ones on the list. I just didn't type them in here. And right off the bat, the communication will be more rule-based. So if a patient is pending discharge tomorrow and there's a barrier, we'll kick off on a schedule the outreach to the providers, whereas in the future that will become autonomous. And again, the same ROI focus I talked about before. We'll move in this fall to autonomous agents that are going to control this more autonomously and essentially propose the overarching plan that a human in the loop, so a case manager, social worker, will approve and then continue to adapt. We're going to be integrating LLM-driven discharge summaries because that clearly fits into this kind of full value chain of the workflow. And layering on some classic rule-based automation where if things like an order comes through when we have a pending task, we'll know that a DME task and a DME order complete each other if they're both about mobility. And then as we look to the future, we've got some interesting vision around how we tackle the depart process and post-acute care. So we think this really fits naturally into a new, more automated approach to depart. Things like agentic DC MedRec, discharge summaries, patient education, et cetera. We do parts of those workflows today. We're going to start thinking about how we do nursing facility or skilled nursing facility placement. So either doing voice messaging or integrated outreach to find appropriate placement for a patient. We don't think calling a million sniffs to figure out what's available for each patient makes sense in the future. And then we're going to move into things like engaging the patient to check on symptoms and risk for readmission and using agents to do some of that post-acute engagement, where historically you either had somebody call them or maybe you had an application that tried to get them to fill out a form. In the new world, an agent can just talk to them like a simple social worker, collect symptoms, and then either funnel them back into the health system as needed, or check them off and say, look, things are pretty good. We're also going to be looking at some predictive analytics, so classic machine learning around discharge date, risk of delays, scores like that. But that will follow after a lot of the agentic work where we think we can have a bigger impact. So I'm going to stop there. If we have questions in the chat, great. We'll probably pause for a second to let people type a few additional things out. And then Josh and Ryan will kind of orchestrate the Q&A and fireside chat for us.
Perfect. David, I have to comment because as a practicing hospitalist, and as somebody who quarterbacks this in the hospital, this sort of resonates with me and why I get so excited and smile when I see certain workflows. And what's really important for folks to understand is the level of complexity of this cannot be understated, meaning every patient is different, is going home on a different day with different requirements, may not be going home, may be going to long-term care or skilled nursing. Some may need a bedside commode, some may need home oxygen, some need these medicines, some need PT. And so when I'm on service and we only, we cap at 16 patients because an academic center, think about managing all of those things across 16 patients. And then think about all the manual work that just goes into my job and really more the resident's job. And then think about all the other people, right? The physical therapists aren't just taking care of my patients. They're taking care of an entire unit or an entire hospital, and the social workers and the case managers. And all these things are happening randomly and things change. So you really have to think of all of the manual work that is going into just getting a patient from hospital to their next stay, whether that's home, whether that's sort of acute care or long-term care. That's an enormous amount of waste in the system. And what's so compelling about this particular use case is that it allows the case managers and the social workers and the doctors and the therapists to spend more time on clinical care, what we went to school for, and not spending enormous amount of time I actually carry around paper with me when I'm on service, and I have all the notes and scribble scratch of everything that needs to be done. And I'm sitting in the chart for hours reviewing notes and seeing where things are. If that's solved for me, then I'm spending a lot more time teaching. I'm spending a lot more time with patients. If a social worker or case manager isn't trying to figure out what available beds are out there, what are the things that are needed, they're spending more time with patients and their families to make sure when this patient gets home, they don't come back in a day or 30 days. So these things solve operational problems, and why I think it's so unique, and commend David and the team on sort of their thinking of this, is that for me, it's kind of the trifecta, right? You pitch this to a group of clinicians and they immediately see the value. From the patient standpoint, they immediately see the value because nobody wants to stay in the hospital longer than they need to, much less get home and not have what they need to be successful when they get home. And more importantly, which is sort of the emerging trend in healthcare IT right now, is the CFO, right? Why does a CFO of a hospital care? This is about capacity. This is about throughput. This is about efficiency, which has impact directly on the bottom line. It's not about replacing people. It's about allowing those people to be more effective and efficient at what they do. So contextually, I think it's really important. And David, the first question I have for you is, you certainly could go build a lot of these workflows and these agents with new and emerging types of code, Claude code, et cetera. But there's a huge difference between building the agents and then having these run at scale with that reliability. And so, how do you think about that? Because everyone's going to have to crack that code. How do you think about what the infrastructure that's needed to solve really the scale problem, not the build problem?
David, you're on mute.
Great question. And while I focus on product and business today, my background was technology and architecture. So that is really critical. When we looked at Vantiq, we basically were asking, like, can you handle large EHR implementation data volumes? And from what we've seen so far, the answer has been yes. And in everything we do, we're not dealing with, tending to deal with 10-bed community hospitals. Most of our customers are large integrated delivery networks. While we haven't rolled out across the VA, which is the largest in the world, we are at some of the largest throughout the US. We've got some of the largest customers in the Middle East. We've got one in Canada going up, another multi-hospital system that's one of the largest in Ontario. And everything we do has to have that scale built into it, along with the reliability. So, what we see in Vantiq is the ability to go in and historically trace exactly what was happening. Why did the LLM respond this way? Or why did we get to this answer? If all we did is build a tool to get the LLM doing a chat, but had no way to figure out what happened when outcome was weird, we wouldn't be able to, one, evolve the system, and two, we wouldn't be able to go back to the customer and say, yeah, we understand this, we can fix it and create that trust. So I think those things both come together. And hospitals, a lot of trust is, can you scale and not break down when you go in production with real systems? Because the clinicians can't have stuff not working.
Yep. Yeah, I think that's so important, right? It's trust has two elements. Speaking from a provider standpoint, it's do I know the system's safe and effective, but also do I know that it's going to work, right? It's interesting. We were having this conversation with Aharon about sort of the gap that's happening between residents now that have no idea what paper charts are like and what it was like to write charts and orders on paper, and watching them sort of scramble when the EMRs go down. It's almost like the system completely stops because nobody knows what to do. Well, for me, fortunately or unfortunately, I still wrote paper charts in medical school, so I'm aware of what to do, right? But for a lot of people, they don't, and so these systems have to be reliable because we're integrating them into a core part of what we do. One thing that's interesting, I'd love to hear your thoughts and Aaron's thoughts, particularly from a customer standpoint, is as you think about where customers are, what problems are really looking to solve for, what are some of the really sticking points that they bring to you to say, look, we want to solve these problems, but we need these things to be proven out in order for us to determine what the ROI is or what the value is if we're going to continue to invest?
Yeah, well, I think the big thing, obviously, and it varies a little bit by region. Again, we do work outside of the US as well, but it's fairly universal. People are asking the question, can you get the patient out the door faster? Because there's actual bottom line value in that. The CFO cares because health systems are squeezed for margin right now. That just really hasn't changed a ton post-COVID. It's still pretty tight. And so anything that affects discharge planning, people are going to care about it. It's part of why we picked this out, along with the fact that I can do it without introducing a lot of clinical risk. Same thing if you move into the surgical space, and there's some overlap with it, but being able to prepare patients for surgery, make sure they show up. They didn't show up and having eaten inappropriately or not held their meds. And then it's same thing, get them out the door and then make sure they don't come back. So, you're seeing, changes to some CMS reimbursement rules around patients that get kicked back post-surgery. So there's a lot of money in that matters. And obviously the patient cares. They don't want to be readmitted with an infection. So both of those are huge. I think the other thing we're starting to see, and this is really, I think, just emerging, is people looking at problems and bottlenecks elsewhere in the health system. So maybe you've got clinics that are focused on prescription renewal, or they've got patients coming in they don't necessarily need to see. So outside of the US, especially where you have value-based care, people are asking the question, can we use automation tools to help funnel the people in we need to see, keep people out we don't, and better utilize resources because they have backed up waiting rooms, they have long wait lists. Outside of the US, we have groups that have, massive surgical backlogs. And so can they use AI to better manage that process and see both financial and outcome benefits? I think all of those are going to happen, as well as just generally a lack of clinicians. I think there was something in the news about us trying to get, another 100,000 qualified clinicians into the US through visa programs. It just underlies the fact that we don't have enough. So while we're looking at things like, can we reduce the number of case managers managing acute discharge, that just flips around the fact that they can't hire enough today. And frankly, it'd be better to put a lot of these people into value-based care in the community where we can have real impact on the system. So I think all of those are going to see a lot of opportunities because it really changes the dynamics financially. And,
Dave, I just jump in pretty quick here, is that, yes, there are problems that everybody knows about that we can help with. But historically, and one of our benefits to customers is that with our platform, we can go to a customer with built-in solutions for stuff that we know that will help, but we're then able to work with them as soon as we get up and running on problems that we may not know about, but are pain points for them. Because even though you might think a hospital is a hospital, like every patient getting out the door is different, really every hospital and hospital organization is different with resourcing differences, different patient populations. And so with our platform and our partnership with Vantiq, we're able to go in and just say to the customer, what are some problems that you have that we can help with? And we're able to help with.
Yeah, and we throw around the word platform a lot. It's becoming really common. I heard this at HIMSS a lot, and I think even in verticals beyond healthcare, we're seeing that organizations are recognizing the need for a platform that gives them the ability to really do two things. They want to control their operations, meaning the idea of sort of sending everything out of the health system or sending everything out to a third party to build something, to do something for them, and then bringing it back, that's going to disappear in large part because whether it's data use agreements or data provenance, security, et cetera. But it is also a cost issue where if I can maintain and control the workflow within my operational tempo, and I can work with partners like TransformativeMed, I get way more value out of these emerging platforms. And I think it's an interesting intersection. We at Vantiq like to think, look, we've solved a lot of the really hard problems so that companies like TransformativeMed can go in, build these applications and help with the transformation. And that sort of unique sweet spot, I think, provides a really unique ecosystem. And I'm interested to hear, as you all, coming off of HIMSS or starting to sort of move this into ideas around beta and beyond sort of design partners, but getting this into production, what are some of the outcomes you're going to be looking for? And what are some of the lessons learned that you hope to achieve that, you know, things are still in pilot and people don't know how to get to scale? You know, what is that sort of meaningful and tactful approach as this does get into production that can be not only shared with the broader community, but really will help continue to define the product?
Yeah, good question. I think the obvious stuff I talked about, which is we got to look at discharge before noon rates first, because it's something where you actually have enough data power to measure it. Length of stay gets complicated. You got to do that at bigger scale. So we're going to definitely focus on that one. And then generally just the impact to clinical operations and workflow, like how efficient are people with it early on. I think the other really critical part of this is I'm a big believer that I can't figure out how to build the right real workflow for how clinicians work without partnering with them. So while we talked about our academic medical center partner, it really is the crux to us making this work. And I think everything from outcomes to lessons learned have to be like co-funneled through them. So, we didn't pull them onto the presentation today. They're looking to get outcomes and present this at future conferences, because they know if they can solve some of these problems, it's like a huge win for them. They want to take credit for it. But I think we have to really learn from them and understand the boots on the ground realities. So I think that's a huge foundation. And some of what Aaron showed and some of the like little nuanced discussions around workflows come from that. We went in with a perspective on how we thought this worked. Even Aaron, having been a nurse on the floor, had a pretty good feel for it. And then there were all these little nuances you had to account for if you wanted to make it work the way people work. Because if an agent's out there telling you to do something or planning for something and you're like, but that's not what we do, it's just going to break and people are going to start ignoring it. So the Vantiq gives us that adaptability to tune it to specific services that may be different at different hospitals. And then, we've really tried to focus on how do we maintain that platform flexibility, meaning it's not just built one way, but we can quickly adapt.
Yeah, I couldn't agree more, right? I often tell people this. The first AI application in healthcare came to the market in 1973. There was one before it, but the real commercial one, and it was called Mycin, and it helped clinicians select the proper antibiotic for pneumonia. And the reason it never scaled was focused on two things: trust in the model output, and it was not integrated into the workflow.
Mhm.
And that's an important lesson because that is still a fact nearly 50 years later, over 50 years later. Um, that's just true. And so I think one of the things that we've often thought about at Vantiq, and I am not a developer by any stretch of the imagination, but I have a little Mac and I'm doing some coding now, and I can get into the platform and sort of build very simple applications because of sort of the way it's visually oriented. And that gives me as a clinician the ability to go, no, no, here's my workflow, and the ability to work with someone like you who can quickly adapt that and do that sort of in my presence is a huge advantage for how these solutions will continuously evolve, because the reality is that the workflow is going to evolve and change. New evidence will come out that says, hey, we should do it this way and not that way, or the risk models will change. You've got to be able to keep up and adapt. And I think that speed, given how fast things are moving, is going to be just crucial. So I know we only have 5 minutes left. I always like to end a little bit early. We'll see if there's any questions from the audience, and then I have sort of one wrap-up question that I think is kind of where the future's going. But we'll just see if there's any other questions from the audience. And if not, interested, both Aaron and David, your thoughts on, as this gets more and more autonomous, how do you see the end user being able to themselves interact and adjust how these agents are kind of interacting with us in their individual workflow?
Yeah, and I see a few chat questions. I don't know if some of these came from the audience or from some internal folks. Josh, do you have anything that you want to queue up and make sure we don't miss questions from the audience?
No, it looks like right now most of the audience Q&A has been answered. So I think just going forward with what Ryan was just touching on would be best for the last few minutes.
Yeah, absolutely. So, um, I think the big thing we'll note is that we're going to continue to present on what we're doing and try and share it with the community. I know, we may have hospitals here looking at how the world's going to evolve. I know a lot of hospital systems are in high learning mode, trying to figure out how AI is going to change their operations and their IT strategy. So we really want to kind of take a collaborative thought leadership approach and kind of get out there what we're doing and then learn from the community. The other one, of course, is as we roll this out, the plan is to publish. Obviously, the quick, easy stuff's white papers, but this is an academic medical center. They're going to probably want to do academic publications as well. We love to support that stuff. Some of our first platform applications were early IT publications into academic journals. So we're going to really try and balance out both what you're seeing from the kind of outcomes, business operations side with the real heavy clinical research, and want to see more of that come out there. And I'm looking forward to having the people we're working with talking about this from their perspective next. I think they have to use it first. It's one thing to say why it's important. We can kind of parrot those messages, but as this starts to have an impact, we really want them to be able to talk about what they're learning, what they're seeing, how they're thinking about, and the impact this has in real life. So that's what I'm really looking forward to. And I think pair that up with the fact that a lot of these tools, it's just technology can move so quick now. Things that felt like they take years in the past, sometimes we're getting them done in a month. And that's just really exciting. Sometimes scary, but also just really exciting. You gotta,
just a minute left, but for the future, Ryan, I have a friend who used the term cognitive overload, and if this is implemented well and right, this is all about reducing the clinician's cognitive load. And what does that mean in practice? It means like we just showed, placing a task on a task list for DME. Well, there's no we probably, I think this on the roadmap for later this year is might as well just tee up proposed orders for those to the primary service, things like that. There's so much time spent now with clinicians going through notes, and it's not the fact that they may miss the need for DME, it's that it might be caught late and it might cause a discharge delay, or the hospital or the organization ends up paying for it because they didn't have time for it to go through insurance. So I really think this done well is a way to help clinicians keep track of things that they need to keep track of, but help automate the things that they don't actually need to keep track of, but still need to get done in the way that they feel like they have to do now.
I agree. Well, appreciate all the attendees. I know this is recorded and will be shared. Have loved working with the Transformative Med folks. I think, again, we always think we've solved a lot of the hard problems so that folks like you all can go build these apps and scale them and together make a huge impact, not just on hospitals' bottom line, which is important, but also make an impact on the clinicians and the patients that they serve. That's obviously my ultimate goal as a clinician. And I think it's just amazing to see these synergies coming together, and hopefully folks take away not only how we've partnered and where both fit into the ecosystem, but really what's coming in healthcare in the next year. And I'm just excited to see the first people sort of pilot this and give feedback, and then really be able to share that with the broader community. So with that, again, appreciate everyone's time, enjoyed the conversation, and look forward to next time.